A patient comes into the trauma bay. There is a bundle of bandages on the chest. Do a head-to-toe assessment. We're doing everything. And as part of that, we take the bandages off. It's really bloody. We're kind of confused. Why is there, we weren't told about any injuries to this part of the chest. So when we take the bandages off, we see a needle and it starts squirting blood. Oh my goodness, what could this be? Well, it turns out that the paramedic in the field had placed a needle decompression right into the right ventricle. So that's why it's so important that if you're going to do this pre-hospital treatment that does have a high rate of failure, that you do it correctly with the right equipment in the right place, because sometimes it can cause more harm than good. So you need to know when to do it, where to do it, and how to do it. It's critical. I'm Zach, a PGY4 anesthesia resident and a former EMT. So let's talk about needle chest decompressions. So you do this when you notice that the patient has the classic signs and symptoms of attention pneumothorax, but most importantly, when they're getting hypotension, when they're showing signs of compromise, and that you cannot get them by without doing this procedure. You do this with an angiocath that's long enough. Oftentimes, failure rates for these are 65% or higher, especially if you're using a needle that's too short, so at least 5 centimeters longer. 8 centimeters has shown some better success. Lastly, do this in the right place. They used to teach when I was an EMT, mid-clavicular line, first or second rib down, right? Intercostal space. Now, you're going in the axilla, high up in the axilla. Less anatomical structures to injure up here. You're not going to stab the right ventricle, which is critical to avoid. If you have any tips or tricks from placing them in the field personally, let us know below.